Hello. I actually have two questions. Maybe I'll just throw both of them out there and you can answer them. The first one is in terms of the research. Again, not to be digging too deeply, but this is sort of on my mind. I was wondering if the research looked at, I know you compared the number of complications in the hospital and at a birth at home, but I was wondering if somebody looked at the severity of complications occurred between a hospital birth. I mean, something as simple as sort of like a tear and an episiotomy, whether it was more severe in a home birth versus a hospital birth or not. And then my second question has to do with perception of what normal progression of labor is in the midwifery model of care and the hospital model of care. I'm one of those people who's watched The Business of Being Born, and so I guess my ideas are sort of more from the United States, but what I got out of it, that you're sort of rushed in the hospital and that kind of stuff, and it just seems that there's a difference between what the perception of what normal birth is and how long it should take and what kind of progression a woman should be having. So if you can speak to that, that'd be great. Thank you.
Well, first of all, severity of complications is a really important part of what we look at. And so we look at hemorrhage and we don't see any difference in rates of postpartum hemorrhage. And you wouldn't expect that because these are the women of similar low-risk status across the groups. But we're very concerned about if you have a hemorrhage at home, are there more adverse consequences because you're at home and not immediately in hospital? And we measure that by things like whether or not there's a requirement for a blood transfusion or whether some further surgery has to take place to stop the bleeding. And we haven't found that. In terms of infections, we've actually looked at things like temperatures and use of antibiotics and haven't found a difference. So it's a really good question. You do need to look at severity of outcomes, but we haven't found a difference in the groups. And the second question, I'll ask somebody else to answer. Okay, so we haven't found that there's more severe tears at home, but if you do compare midwifery groups, whether or not it's home and hospital, again, you don't find a difference. We do find more third and fourth degree tears amongst midwifery planned births, but we also find less use of forceps. But the difference between home and hospital is not difference in terms of third and fourth degree tears.
I'll try and address the second part and then also hand it off to my colleagues who attend births as far as length of labor and normal length of labor. We do have, we have some questions that have been passed up to, and we will, don't worry, we will get to those. But as far as length of labor and how you manage that and what you perceive as normal, people who pay attention to the literature understand that what we used to use as a guideline was work that was done by somebody named Friedman, who characterized what he thought the normal labor curve or pattern was. It was based on about 500 women, which is not a lot in research terms, and it was based on statistical methods that we don't really use anymore, where he sort of synthesized a number of different labor codes into one and called that the normal labor curve. That has been looked at quite a lot now. There are other researchers, Zhang and Johnny and O'Connell, and I can name a bunch of them, and the data keeps coming up that labor is longer than we thought it used to be. We used to think that labor should, for first-time moms and second-time moms, that there were differences, but that there was an average. You know, they used to say that latent phase of labor, the outside range of limit was 20.1 hours and 11.7 hours for the active phase of labor, and you know, and that was for first-time mothers. And there were others, you know, averages, whether it was 12 hours and how long the second stage. Friedman said that the second stage was about 2.9 hours outside limits of normal, but that was often you hear in community understanding that was understood as 2 hours. Well, you know, when I learned math, 2.9 was closer to 3 than 2, but that's not how we usually had practiced it. It was 2 hours. 2 hours without progress, yes, people should be paying attention, people should be with 2 hours of pushing and the baby's not moving down. Is it the effectiveness of the pushing? Is it her position? What's going on with the baby's position? But what we understand now is that if the mother is doing fine and the baby is doing fine, that length of labor alone, whether you're in first stage or second stage, shouldn't be the deciding factor. The issue is how long is too long, and at what point do you get to a point where the mother or the baby reacts? They get too tired, they get exhausted, or they react to what's going on, or you are, pushing things into an arena where, for whatever reason, the baby's head is cocked, the woman, the way her early part of the labor, she was up a few nights, she's exhausted. There are lots of reasons, but whether she needs some assistance. I think that most practitioners that I work with now do ask those questions and are able to negotiate, at least in Canada, where we talk about, people say, well, part of the job of being a midwife is being patient. I think that's true for anybody in birth. And, for those people who are not used to seeing, I know that Brenda stays in the room when her ladies are pushing. Not all physicians do that, and not all physicians stay around during labor. And so if you don't, again, it's an exposure thing. If you don't see the range of normal, and a lot of women are staying home and then coming into the hospital, you don't necessarily understand that long labors can be normal too. So, but I think that I don't think that there's a lot of disagreement around that now.